Hello, my name is Jackie Dewey, and I am a Director of Gemtesa Marketing at Sumitomo Pharma America. On behalf of Sumitomo Pharma America, I'd like to welcome you to today's educational program entitled Partnering with Patients for the Pharmacological Management of Overactive Bladder. We are very fortunate to have two excellent speakers with us today to facilitate this program, Dr. Scott McDermott and Dr. Chanel Wilson. Dr. McDermott is the Director of Bladder Control and Pelvic Pain Center at the Alliance Urology Specialist in Greensboro, North Carolina. He is also a clinical assistant professor in the Department of Urology at the University of North Carolina in Chapel Hill, North Carolina. Dr. Wilson is a female pelvic medicine and reconstructive surgeon at the Metro Atlanta Urology and Pelvic Health Center in Kennesaw, Georgia. She is also the founder of Urology Unbound in Atlanta, Georgia. Now at this time, I will turn things over to Doctors McDermott and Wilson.
Thank you so much for the introduction. Again, this is Partnering with Patients for the Pharmacological Management of Overactive Bladder. I am Dr. Chanel Wilson. I'm a urologist and urogynecologist in Kennesaw, Georgia.
And I'm Dr. Scott McDermott. I'm a urologist in Greensboro, North Carolina, and I subspecialize in avoiding dysfunction and reconstruction of the pelvic floor and gender urinary system.
And we are both paid speakers, and for this program is on behalf of Sumitomo Pharma America, and we are excited to do this talk. So just a quick overview of what we're going to discuss this evening. So we're going to review the impact of overactive bladder and talk about the importance of shared decision-making when we are discussing treatment options with patients. We'll go through about 2 cases just to see how this works in real life. And then we'll also review the efficacy and safety data of Gemtesa, as well as discuss Gemtesa as a potential treatment option based on the information obtained from the Empower clinical trials.
Well, thanks, Chanel. I'm happy to be here. It's Dr. McDermott again from Greensboro, and I want to thank Sumitomo for the invite. I know Dr. Wilson and I love speaking about overactive bladder, and in this case, we're trying to come up with some tips perhaps just to help you treat these patients, and hopefully we can sort of reach that goal to help you drive excellence in this patient population. I think we all know the definition of overactive bladder, don't we? Urgency with frequency and or nocturia, plus or minus urge urinary incontinence. For a number of years, we have felt that urgency is the driving symptom, because if you have urgency, you have frequency. If you have urgency, you'll get up in the middle of the night. And if you have urgency, if you don't get there in time, you'll leak, and that'll be urge incontinence. Overactive bladder is a highly prevalent condition, and bother due to OAB actually increases with age. It's highly prevalent. Approximately 35 million Americans suffer from overactive bladder. The prevalence and bother due to OAB increases with age in both men and women. It actually is equally common in men and women, and if you have urgency and frequency, you do have overactive bladder. Overactive bladder is 3 to 5 times more likely in African American and Hispanics than versus white population. The bottom line is these patients are in our office every day, and they really could use our help. There was a national poll of 2,000 women aged 50, 80 years of age. It was a healthy and aging survey, and 50% of the patients actually had urinary incontinence in the last year. 41% described their leakage as either a major or somewhat of a problem, and 1 in 3 women had leakage episodes almost daily. This slide, I think I sort of like to say, overactive bladder is underdiagnosed and it's undertreated. And I think it really is for 2 main reasons. Many cases, the patients aren't telling their physician because they're embarrassed. They're not sure if there's a good treatment. And they think it may be a normal consequence of aging. And if you look at that box to your left, the average time a woman waits or a patient waits to tell their doctor is 3.1 years. In this survey, 44% of patients said that their physician had not asked them about the problem. They had to bring up the problem. And to your far right, these patients really want to be seen, and many of them are being seen by a urologist. The AUA guidelines have just changed. We had first, second, and third line therapies. It was sort of a tiered approach in the initial guidelines. Now it's sort of a menu where it just sort of presents all the treatment options for overactive bladder, which we know, I'll just review briefly: behavioral therapy like the Holding drill and fluid modifications and pelvic floor exercises. Then there's pharmacotherapy, the beta-3 agonists, the antimuscarinics, the minimally invasive therapies. I'm glad they call them that now. The botulinum toxin, percutaneous tibial nerve stimulation, sacral nerve modulation. The invasive therapy, a bladder augmentation, really is so rarely done now, probably because of all the other treatments we have, especially the botulinum toxin. When I see all these treatments, it's sort of cliche to say, but they're sort of tools in the toolbox, but they're imperfectly good therapies. It's a lot of try this, or even combine them. And certainly the more tools we have, the better. What we're going to talk a little bit about today, Dr. Wilson and I, is shared decision making. And what that really is, it's a relationship that you have or a discussion with the patient. And the physician presents all the treatment options, their pros, their cons, their risks, but really encourages the patient to tell the physician what is their preference, what are their goals and concerns. And what it really does, it builds a lot of trust between the provider and the patient. And it really allows the patient to make a nice informed decision, doesn't it? And it really does ask us to listen to our patient and what they want. I like that bottom bullet on this slide. I'll read it to you. 87% of urologists report regularly discussing treatment options for overactive bladder, but only about 2/3 of us actually elicit what the patient would like, what their preferences are. And I think on busy days, I'm probably guilty as charged, but it is a wonderful thing, the shared decision making. When we're looking at the shared decision making in the context of overactive bladder, what we're really doing is we're presenting the treatment options to the patient and discussing the relative risk, the pros and cons, even the invasiveness of some of the therapies. It's interesting, overactive bladder is what is referred to as a preference-sensitive condition because what it has is multiple equally effective treatment options to choose from. So it's really a menu that you get to offer to the patient and really ask them what they prefer. If you think of the word share, I'll sort of walk this through. You want to seek your patient's participation. You want to encourage them to take part. You want to help the patient explore and compare treatment options. We've discussed that. You want to assess your patient's values and their preferences. You want to reach a decision with your patient. And then this is important. You want to always evaluate your patient's decision, short and long term. When I go through this with the patient, there's a couple of questions that I really like to ask. In fact, a couple of them are on this slide to your right. It's really, what is your goal? What I mean by that is, what is most important to you? And then what concerns you have, what concerns you the most? So what is your goal and what are your concerns? And always, once again, short and long term, let's plan to review how this treatment decision is working in several months from now. We can always change paths.
All right, so we're going to go through a few cases, and we're going to start with Susan. Susan is a 63-year-old hospital administrator, and she comes in with a very run-of-the-mill chief complaint of frequency and urgency. So, Susan has multiple daily urgency episodes. She goes to the bathroom over 8 times a day. Her workday is interrupted because she's always going to the bathroom, and she's got anxiety around finding a public restroom. When you look at her medical history, she looks like, really our typical patient of this age group. She's got hypertension, diabetes, high cholesterol. She's had a TIA. She's got Sjogren's and anxiety. We've already ruled out a UTI. We know she has no hematuria and she has no elevated post-void residual. We look at her medication list, and again, it looks like the medication list of the majority of patients in our practice. And speaking with Susan about the treatments she's tried for this overactive bladder, she's tried pelvic floor exercises, she's tried bladder training, she's probably also been told to cut out caffeine and to make sure that she's controlling her constipation. She tried OAB medication a few years ago, but she had to discontinue it due to dry mouth, which is not surprising because she's got Sjogren's disease. And she really wants a convenient dosing schedule because ultimately her main issue, she's got anxiety that's causing her to change her plans. She's having to live her life around her bladder symptoms. So, when we're speaking to Susan, we can identify that she's already tried behavioral therapy and that's been insufficient. And she's tried medications, but that's also been discontinued because of the side effects. Ultimately, Susan's symptoms are getting worse. She's constantly rushing to the bathroom and it makes it hard for her to get work done. So, if Susan has all these issues, why did she discontinue these medications? And also, why is she just now coming back? Well, if we look at the data, we see that approximately 70% of patients are going to discontinue their OAB medication after that first prescription. And only about 9% of the patients report being very satisfied with their current treatment plan. Now, even when these patients are discontinuing their medications, less than 6% of them are changed to a new medication within 2 years. And so we see that people are seeking help for this condition, but for whatever reason, they stop the pharmacologic medication therapy and they don't seek help again for a very long time. And in this time period, they're experiencing impact. So when we look at the top 4 patient-reported reasons for discontinuing OAB medications, it's usually due to side effects or because it didn't work as expected, or maybe they switched to a new medication, or they just learned to get by without the medication just by masking or just, again, building their life around their bladders. And so even though 75% of patients rate follow-up conversations as very important, they rarely occur after this diagnosis. And so that can be why we're seeing so many patients who discontinue their OAB therapy. So again, in speaking with Susan, we let her know that there are several treatment options, but ultimately we want to choose something that she's going to stick with and that's going to work for her. So when asking her, what are you looking for? Susan says, I'm hoping that the new treatment will help to manage my urgency symptoms because they are so disruptive. And when we ask Susan, what's the most concern or what concerns her most about, her treatment and what potential side effects she says that she's tried medications in the past. She discontinued it because of the side effects. And ultimately she needs to find a balance in which her symptoms are managed, but she doesn't have bothersome side effects. When we ask what's the most important thing for in terms of treatment, she wants something that's going to fit into her lifestyle. She's busy and she needs something that's going to work and she doesn't have to pay a lot of attention to. So based on our conversation and her speaking to Susan about her goals and her concerns, I want to speak with her about the risks and benefits of pharmacologic therapy options.
I'm going to speak about Joyce. Joyce is a patient who I see many times in my continence center. Joyce is 74 years of age, and her chief complaint is urge urinary incontinence. So Joyce's symptoms were urgency, frequency. She was voiding 8 or more times a day. She was having daily urge incontinence episodes, at least 5 per day. It's interesting when you hear the impact of her condition on her. In the past year, she actually fell trying to get to the restroom in the middle of the night. That's actually, to me, a safety issue or a safety concern. She has stopped going to exercise classes and frequently turns down plans due to embarrassment over overactive bladder and anxiety in public. So she sort of has these avoidance behaviors. Her medical history is pretty typical of a patient of her age. She has irritable bowel syndrome, osteoporosis, depression, atrial fibrillation, asthma. And her workup really from a urologic standpoint was within normal limits. And medications are listed, hyoscyamin, nortriptyline, and others listed on the slide. She's never explored behavioral therapies, and she's actually interested in medication, but is worried about side effects and interactions, especially drug-drug interactions, especially given her age. In the shared decision making, if we think about the questions are what is your goal? What are you hoping to get from this therapy? And what are your concerns? And when I asked her that, she said, I'm interested in actually taking a medication to help my overactive bladder symptoms, but she is worried or concerned about side effects and whether or not there could be a drug-drug interaction. When we're prescribing medication, in this case for overactive bladder, in any patient, but especially older patients, we really have to be concerned for potential side effects or safety concerns. If you look for warnings or precautions on anticholinergics and beta-3 agonists, they're listed on the slide. If you look at the ones from the Medicare and Medicaid services, when you're using an anticholinergic, we recognize the side effects like dry mouth, constipation, blurred vision, gastritis, etc. Beta-3 agonists we'll see during this talk is stuffy nose, headache, etc. The American Geriatric Society has placed anticholinergics on the Beers list, and it's primarily because of the potential concern for them causing cognitive decline or impairment. And they really ask you to try to reduce the dose if using them in the elderly, or actually or not use them altogether. If you look at the AUA and our Urodynamic Society, there's a number of precautions and warnings as well. You want to use extreme caution in giving an anticholinergic in patients with narrow angle glaucoma, but also in patients with impaired gastric emptying and a history of urinary retention. Again, caution in patients using other medications with anticholinergic properties. And with beta-3 agonists and anticholinergics, always use caution in the frail elderly with overactive bladder. This was an interesting consensus statement from the AUG Society in 2021, and they really put out a number of bullets or concerns with anticholinergic medications and their associated risk of cognitive impairment, dementia, and Alzheimer's disease in the general population. The first bullet is really summarized and says, if you're going to give an anticholinergic to a patient, in this case, a woman, that this potential risk or association with cognitive impairment should be discussed with the anticholinergics. In the fourth bullet, they recommend in their Choose Wisely campaign, the use of anticholinergic medications to treat overactive bladder in women over 70 years should be avoided. They go, if you look at some of the other bullets, if you're going to use anticholinergics, use a lower dose, or perhaps use one that is thought not to cross the blood-brain barrier as much. And also strongly consider the beta-3 agonist in treating overactive bladder, but other third-line therapies like botulinum toxin, neuromodulation therapies like percutaneous tibial nerve stimulation and sacral nerve stimulation. So when we think about the shared decision-making with Joyce, what I've asked her first, what are your treatment goals? What are you hoping to achieve from therapy, and what are your concerns? And as I've said earlier, she actually would love to take a medication that controls her leakage episodes. She's wishing to hopefully take meds, but she is concerned, as I said before, about potential side effects. And earlier on, she had mentioned drug-drug interactions. Based on her goals and concern, I walked her through all the different pharmacological therapy options, but also afterwards said, are you aware of behavioral therapy? And we discussed things like a holding drill, fluid modifications, and pelvic floor therapy. In going through this, I've turned to her and I said, listen, now that we've talked about behavioral therapy and pharmacological therapy, what would you like? And she said, well, I thought I want to try a medication first, but let me start with the behavioral therapy that you've walked me through. And I just want to do a little bit more research and thinking about medications. Chanel, what do you think? Do you think we see a lot of patients like this? I saw your case, Susan and Joyce, in your practice. And what are your thoughts in terms of would the beta-3 agonist be good for them?
Yeah, definitely. So in my practice, both of these patients, I would bring a beta agonist to them. They also sound like my patients just because they want to do behavioral therapy, which is definitely a great option because ultimately we want to get our patients better in the way that works best for them. All right, so we're going to go a bit through the data and the trials. And so we're going to go through the Empower clinical trials. But before we do so, let's go over the important safety information. When looking at contraindications, Gemtesa is contraindicated in patients with known hypersensitivity to vibegron and any components of the product, which of course makes sense. When we look at the warnings and precautions, like all medications treated for OAB, we want to warn our patients about the risk of urine retention, which has been reported in patients taking Gemtesa. The risk of urine retention may be increased in patients who have bladder outlet obstruction and also patients who are taking muscarinic antagonist medications for the treatment of OAB. So we want to monitor these patients for symptoms of urine retention, particularly in patients with bladder outlet obstruction and patients who are taking these medications that are also treating OAB, and discontinue Gemtesa in patients who develop retention. When we look at adverse reactions, the most common adverse reactions, so those occurring in greater than 2% in patients who are taking Gemtesa, were headache, urinary tract infection, nasopharyngitis, diarrhea, nausea, and upper respiratory tract infections. So Gemtesa is a selective beta-3 adrenergic receptor agonist. So when we look at the different beta-adrenergic receptor subtypes, there are three. The ones that are primarily focused in the bladder are the beta-3 ones, and Gemtesa has selects specifically for that receptor. By activating these beta-3 adrenergic receptors, Gemtesa is able to relax the bladder detrusor muscle to increase bladder capacity. And because we know that bladder relaxation is predominantly mediated by these receptors. So now when we look at the Empower phase 3 study, we see that vibegron was studied in over 1,500 patients with OAB in a 12-week phase 3 multi-center randomized double-blind placebo and active controlled study. They were able to randomize these patients to placebo, Gemtesa, or active control. And the patients in the study looked like the patients who show up in our clinic who typically have these symptoms. The mean age was 60 years old, with 85% of them being female and 77% of them having OAB wet compared to 23% having OAB dry. 42.9% of these participants were over the age of 65, with 12.2% of them being over the age of 75. So we really got a good look at how Gemtesa acts in patients of all ages. The patients had to be treatment naive or had to have had treatment for medication with a prior anticholinergic or beta-3 agonist at least 12 months before the study. And their symptoms of overactive bladder needed to be present for at least 3 months, with an average of greater than 8 micturitions per day and greater than 1 urge incontinence episode per day for those who had urge incontinence, and greater than 8 average micturitions per day, and an average of greater than 3 urgency episodes per day. So when we look at the what were they trying to find out with this study? Well, they had endpoints. The co-primary endpoints were looking at the change from baseline in the average daily number of micturitions and urge incontinence episodes by week 12. When looking at the key secondary endpoints, they really looked at those key symptoms of overactive bladder. So the change from baseline in the average number of daily urgency episodes at week 12, looking at the percent of OAB wet patients at week 12 who had a greater than 75% reduction in the total number of urgency episodes, urge incontinence episodes in 24 hours, and those patients who also had urge incontinence, who had overactive bladder, but had a greater than 50% reduction in the total number of urgency episodes in 24 hours. The efficacy data was collected using a 7-day patient voiding diary, and the analysis was completed using FAS, except for the incontinence episode endpoints, which used the FAS-I. All right, so when we look at the results of the Empower study for these 12 weeks, we can see that there's a statistically significant reduction in the average number of daily urge incontinence episodes at 12 weeks, which was one of the co-primary endpoints versus placebo. Looking at the graph, we can see that there was an approximately 60% least-squares mean reduction from baseline in the urge incontinence episodes versus the 40% with placebo. And it's also important to note that similar results were seen in elderly patients older than 65 and 75 years old when compared to looking at patients who were younger. So then when we look at frequency, the reduction of frequency, which was the other co-primary endpoint, we see that Gemtesa also had a statistically significant reduction in the average number of daily micturitions at 12 weeks when compared to placebo. And again, this was noted in patients of all ages. When looking at the proven reduction in urgency episodes at 12 weeks, we saw a statistically significant reduction in the average daily urgency episodes at 12 weeks, which was that secondary endpoint versus placebo. This is the first and only beta 3 agonist with proven urgency data in its label. And so, to Dr. McDermott's point earlier in the presentation, urgency is one of those key driving symptoms of overactive bladder. And we were able to see in this Empower trial that Gemtesa was able to specifically reduce that. So when looking at some of those secondary endpoints, the percent of OAB wet patients with a greater than 75% reduction in their daily urge incontinence episodes at week 12, we see that 52.4% of patients on Gemtesa, when compared to 36.8% of patients on the placebo, were able to see that reduction of greater than 75%. And that's, of course, based on their bladder diaries. So when we look at the proven safety and tolerability at 12 weeks when compared to placebo, Gemtesa, the adverse events that were reported in greater than 2% of these patients at 12 weeks included headache, upper respiratory tract infection, nasopharyngitis, diarrhea, and nausea. But 98.5% of patients in the Gemtesa arm did not need to discontinue the treatment due to these adverse effects at 12 weeks. So Gemtesa is the first and only beta-3 agonist with no clinically significant impact on blood pressure, which is, of course, huge in our population. Hypertension and increased blood pressure rates when compared to placebo at 12 weeks were not statistically significant. So it's the first one that has that is without the blood pressure warning in its label. Similarly, this medication does not have any drug interactions with those CYP2D6 substrates. So the medications that many of our patients are on, fluoxetine, metoprolol, amitriptyline, risperidone, all of these different medications that our patients are often on, so we don't have to worry about giving the Gemtesa when the patients are on this medication. So just again, to reiterate the safety information, one of the main warnings that we need to give patients when we start them on any overactive bladder medicine, Gemtesa included, is that risk of urine retention. So we want to make sure that they know what to look out for. I always tell patients to look out for increased urination if your symptoms get worse instead of better, or you feel like you cannot empty your bladder, to make sure you let me know, because that is, of course, one of the safety issues.
You know, following the phase 3 placebo-controlled studies in the United States, what the FDA wants is a long-term extension phase. In this case, it was a 40-week extension phase. And what they're really looking for, and what industry is looking for in doctors and providers, is that there aren't any safety outliers that may have been missed in the first 12 weeks. So after the 12-week double-blind treatment period, patients were randomized to Gemtesa or an active control, which is an antimuscarinic. The average age was 61. 78% of the patients in this extension phase were female. 78% had OAB wet, 22% had OAB dry, and they were followed for an additional 40 weeks. The primary endpoint in an extension study for an OAB medication like Gemtesa is you're really looking for treatment emergent adverse events. Is there any other new side effects or additional side effects or safety concerns? Well, you know, they also looked at, of course, efficacy, because they were studying these patients. And there was 3 or 4 that were primary looked at. They looked at the change from baseline at week 52. That's from time 0 to week 52. What was the reduction in daily number of micturations in all of these patients? They want to see the change in baseline in urge urinary incontinence episodes from time 0 to 52 weeks. They wanted to look at the change from baseline at week 52 in the daily number of urgency episodes. Now, an exploratory endpoint was of the OAB wet patients at 52 weeks, what percent were not leaking on a 7-day diary. So let's just walk through those one at a time. This is the reductions in urge urinary incontinence episodes observed at 52 weeks. To your far left is time point 0. And you can see this rapid decline in number of urge incontinence episodes down to 12. Well, that's the first 12 weeks that Chanel has presented already. And you can see when the patient stayed on Gemtesa in teal, that the reduction in urge incontinence episodes persisted throughout the 52 weeks. Let's go to the next slide. This is reduction in frequency observed at 52 weeks. It really looks like a similar pattern, doesn't it? From time 0 to 12 weeks in the first 12-week placebo control phase, you have reduction in frequency. And then if you follow that teal color in the lower part of the slide, you can see the reduction in frequency persists. The next slide is urgency episodes, the change in baseline. If you look at time point 0, you have that first initial decline of 3 urgency episodes at 12 weeks, but then they continue to have that reduction in urgency episodes out to 52 weeks. I do like this slide. It's and we're going to concentrate first on the right side of the slide, it's what percent of the patients had 100% reduction in daily urge incontinence episodes in this case, at 52 weeks, and it was 41% versus the 34% was with the active control. And interesting, just to remind you, this didn't come out in the early presentation, but in the first 12 weeks in the placebo control phase, 29% were not leaking on a 7-day diary versus 23% in the placebo arm. And I just think that's nice data, actually. As far as side effects or any new events, what is put on the label when you're in this 40-week extension phase, is there any new adverse events that occurred in at least 2% of patients or greater that was new, that wasn't something that already was picked up in the first 12-week placebo control phase? And there was one, it was bronchitis, and it occurred in 2.9% of patients. To reiterate, the adverse reactions that are most common with this medication occurring in 2% or greater with Gemtesa are headache, urinary tract infection, nasopharyngitis, diarrhea, nausea, and upper respiratory tract infection. You know, we've talked about efficacy, we've talked about adverse events and safety, and as you know, this medication is one dose of 75 milligrams. There's no titration. It's with or without food, and you can crush it. It actually can be crushed and mixed with a tablespoon of applesauce and taken immediately with a glass of water. Chanel, what do you think about your patient? I'll leave this one, and I'm going to go back to mine, and we'll finish up.
Definitely. So, Susan and I spoke about more about her goals, and ultimately she was prescribed Gemtesa, and I decided to evaluate her at 3 months. So when she came in, she said she'd been doing well. It helped her frequency symptoms. It fits with her life. So ultimately, she's doing well with Gemtesa.
And Joyce and I, remember Joyce came in initially, remember her goal was, I'd like to have a medication that controls my symptoms, and she had concerns of side effects. And walking her through the pros and cons and risks of medication and also behavioral therapy, she initially chose behavioral therapy and wanted to think about meds. When she came back on behavioral therapy, it was helping some, but she hadn't reached what I call her treatment goal. So actually, I put her on Gemtesa, and then 3 months later, she follow up, and her sort of report is down below. She was leaking much less, she was going less frequently, and she really was not, and in my opinion, wasn't having side effects or drug-drug interactions, and she was content with the medication.
Thank you so much for your attention.